Thank you for having me here today. Because time is short, I wanted, before I began my short presentation, actually to cite 4 takeaway points that I'd like for this committee to consider. One is that in the United States, state law matters. And in saying that, I feel like a doctor must feel when he gives a bad diagnosis to a patient, because state law is really messy and it's dynamic. State legislatures can react to things like a data sharing proposal and do things. And some states are refreshingly unorthodox in how they handle issues. I see what this committee is doing as sort of being on the magnitude of the Apollo moonshots. You're doing something that's really big, and it's important, and it has scientific and cultural significance. And when you do something like that, you're going to have a list of 5,000 things to do, all of which are really messy and complicated. I think about 1,000 of those issues may be state law issues here. And if you don't deal with them, you get Apollo 13. There's some things you can do, and I'll talk about those ways you might approach that problem. Second point I really want to stress is that it is not safe to assume that FDA's human subject protections are like the common rule. They are the same if you're doing a human subject in an interventional study, but FDA's regulations are actually quite different in their handling of data, which is the issue you're dealing with. So that needs to be carefully dealt with. Another thing is that, ironically, the HIPAA privacy rule in its new incarnation that went into effect recently has some provisions that dealing with the pricing of data-related services for data preparation. These strongly affect the structures that will be optimal for what you're doing and the incentives that parties will face to participate. And really what you're doing is creating a large common infrastructure. And commons exist in many other contexts, common meadowlands, common power systems. You need a combination of methods to get this to work. Voluntary cooperation is wonderful, but it never usually gets the job completely done. Publicly funded common infrastructures are wonderful, but at some point there may not be sufficient funding for the NIH or some other governmental entity to fund all of this. Oh, the private sector has to be involved, particularly here where you have really active private sector entities that produce a large part of the clinical trial data. Very difficult to get them to be involved. If you use compulsory methods, you can run into takings issues under the Constitution. You just can't take people's capital investment away without, just because it's a good scientific idea. And even if you force people, private entities, to share their data, you can't force people to provide services. That's involuntary servitude. And so you need people to want to provide all those ancillary services that are needed to prepare the data to get it into a common model. And you need them to want to, and that means a market-oriented solution. These new HIPAA provisions are very important in setting the framework for how those incentives will work. The final thing I wanted to say, and this is a more remote issue, but to the extent the government is making decisions about who can have access to data and not, there are some potential First Amendment issues. You cannot just restrict information because you think people wouldn't make good use of it. That can be problematic. So the process needs to be attentive to potential takings issues and potential First Amendment issues. Now, with that, if I can switch to my second slide, well, where did I go wrong?
It's hard to...
I've got it now. Thank you for your help. I'm a professor, and I have some research support, and the views expressed today are my own views and not the views of my employer or the state of Texas. Have to say it. To provide a privacy analysis requires additional information beyond which is clear yet, such as whether it's going to be voluntary or compulsory sharing, whether it's purely prospective or whether it's going to go after legacy clinical trial data. And it's very important to know who are the data generators and holders that will be participating. As has been mentioned, we have the Privacy Act and other laws that apply to governmental data holders. We have the HIPAA privacy rule that applies in this context, to simplify it, to covered entities that would be in the nature of entities that provide health care and conduct electronic transactions when billing for it. And the common rule, which is federally funded research and privately funded research that is done at an institution that has a federal-wide assurance in place that puts all of its research under the common rule. I just want to point out that part of the trove of clinical trial data that exists could be subject neither to the HIPAA privacy rule nor the common rule. Your privately funded clinical drug trials conceivably could be outside of both of these rules. When they do apply, HIPAA and the common rule now allow general consents to future work, research, which will be helpful with prospective studies, but they have provisions that allow access to de-identified data, and they have public health uses do not require consent, and they have waiver provisions. Now, for these studies that fall outside this, they may be under FDA's regulations, which are quite different. FDA does not define a human subject as including a person about whose data an investigator becomes aware. It's people who are in a clinical trial. And FDA's regulations are not clear whether FDA is even regulating the privacy of data generated in clinical trials after it's generated. So there's a potential issue here of whether subjects of FDA-regulated clinical trials are adequately protected. And that needs to be addressed, I think. And then furthermore, there's no provision for a waiver of consent as we know it under the FDA regulations, which has some implications. Fortunately, as I say, it's not clear FDA's regulations even apply to this disclosure of secondary uses of data. So, but this is an issue I think is very important. I have about 1 minute left, and I just have 2 more slides I'd like to get to. There was a National Commission report some years ago. This was the companion to the Belmont report. Belmont dealt with ethical issues. This report dealt with regulatory framework. And it came to the conclusion that unconsented use of identifiable documents is ethically permissible, subject to various provisions here that look a lot like the waiver provisions of HIPAA and the common rule. Notice this issue of consent being impracticable. The problem this committee faces isn't one of practicability as we usually know it. Practicability deals with things like, can you get access to the people to get their consent? Your problem is that you need universal consent. You need the whole clinical population to participate. That's a different problem. Last slide. National Commission felt that this was an essential ethical underpinning for any waiver of consent. It's not now in the common rule and HIPAA. It should be. This echoes things that were said yesterday. Thank you so much.